Good morning, good afternoon, and good evening, everyone. My name is Julie Noel. I'm EUROSPINE's Director of Education and Research, and I am proud to start and introduce you to this webinar tonight, which we will be talking about the endoscopy program in EUROSPINE. But before that, I would like to tell you all about EduWeek. EUROSPINE EduWeek is Europe's leading education event for professionals, offering expert-led courses tailored to different stages of your career. And this is for all aspiring spine surgeons and residents to build a strong foundation in spine surgery with essential knowledge and technical skills, and for surgeons who want to advance their skills in expanding their expertise in key areas such as degenerative diseases, deformities, trauma, and tumors. And of course, this is also for experienced surgeons handling complex cases, enhancing their surgical decision-making, and refining advanced operative techniques. The approach of EUROSPINE's EduWeek is actually, it is there where you can have be updated with advances, you are learning from the renowned faculty, you get hands-on training, and more importantly as well, you get to have networking opportunities with your peers. Now, EduWeek, as it offers a unique opportunity for spine care professionals to access a comprehensive learning in one place, the diploma modules, the research course, and now the endoscopy course, which we're going to be talking about tonight, or this morning or afternoon. The endoscopy course is an integral part of the EUROSPINE EduWeek, our flagship educational event. And the endoscopy course would be adding you a practical hands-on element focusing on minimally invasive techniques, complementing the theoretical and clinical foundations provided in other modules. So here, let me take the opportunity to introduce our chairs of the endoscopy, is Bertrand Debono and Frank Hassel. We would like to invite you to this webinar because this is going to give you a clear inside look at the endoscopy course, what you will learn, how it is structured, and what and who it is for. It's also a space for you here to talk with the questions and ask them live, and we may even invite you to join in with them and discuss with them so that you can make an informed decision about your participation in the endoscopy. So with regards to your participation, we want you to attend again here, hands-on training, step-by-step learning, a blended learning approach where you have asynchronous learning, and then you have the hands-on and also the case-based discussion. Just a quick fact, live session dates and time is the 26th of June, and the advanced spinal endoscopies in the 27th of June. It will be in IRCAD in Strasbourg. We have a maximum attendees of 24 delegates, and these are the registration fees. The introduction to spinal endoscopy is already fully booked, but I think it would also be worth listening here so that you could also think about being waitlisted or thinking about the 2026 participation. So please welcome Bertrand and Frank.
Hello, welcome from us as well. Good evening. Overwhelming attendee list here. Yeah, so I don't want to talk too much. Julie just announced it. We are so happy to give you this year 2 days of endoscopy. Spinal endoscopy is one of the most techniques to learn in, and we are going even more minimal invasive with these techniques to the spine. So it's a good option, and I'd like to welcome as well Bertrand to say a few words to all the possible delegates here.
Okay, hello everybody. I'm Bertrand Debono. I'm a neurosurgeon and I'm working in Paris and Versailles. I'm very happy to be part of this new adventure in the EduWeek. 2 years ago, I as a member of the EduWeek board and the educational board of EUROSPINE, I suggest to create these dedicated days on endoscopy because I observed it was a lack in our wonderful EduWeek, and it was a growing pressure of endoscopy in every country, and not only in the peak in South Korea and Germany like 10 years ago. And it was impossible for us in EUROSPINE not to offer to you, attendees, a specific meetings concerning endoscopy. So with the help of Frank, we try to build an attractive program. All the theoretical parts are e-learning, and in Strasbourg, in an incredible place, in one of the best lab that I know, you have only practical learning with models. No CAD lab, it's model, but I was surprised last year for our first session how the quality of the models are improved since a very few years. And it was our first attempt, but we were all very convinced that we have to go on in this direction and to propose this year an advanced course. So be welcome, and you will find, I don't want to monopolize the speech, but you will find all options of endoscopy. You probably know there are monoportal guys, biportal guys, and we will speak about all these techniques, discuss the advantages and the drawbacks of each technique, the dedicated and specific procedure of this, and with just at the end of each session, we will have a case-based discussion of complication of a specific indication of each of the techniques, and you will be able to try all these both techniques in the lab. So be welcome in Strasbourg, and we hope you will follow us in this adventure with Frank and I and all the team of the EUROSPINE EduWeek.
So maybe I just invite everybody here. You have already a Q&A, actually. Yeah. I could the question here was, is the course an e-learning or it's a physical presence? So I might answer this in the beginning. We said EUROSPINE is having a blended approach learning, which means that first of all, what you do is actually you have e-learning modules or videos that you have to go through in your own time. After that, you have to go to Strasbourg, and you begin with a practical skills lab, and then after you have case-based discussions. And I think maybe Frank and Bertrand, you could elaborate on the case-based discussions. What do they expect from there, actually?
Yeah, case-based discussion. Actually, it's a good learning tool. So each of the faculties just bring their cases in, and some of the delegates already who started with endoscopy might bring some cases as well. So we can discuss all of these, and we can go through the techniques and the indications. Because, like in all the spinal techniques, indication. The right indication for the right surgery is crucial. So we have to focus here on these case-based presentations, and these led to really excellent discussions in between all the faculties, as well with the delegates.
I have a follow-up question on that, Frank. So, I mean, you speak about some participants actually bringing their cases. However, if I am just starting, what is it there for me if I join the introduction of the spinal endoscopy course? I mean, what do you recommend? What should be the previous experience I have in endoscopy before joining such courses?
You don't need to have any experience in endoscopy. You just have to follow the e-learning. It will be online in May, I think so, in May. And we suggest some readings and some high-level papers just to have a pre-culture of endoscopy. But after the learning, you will be acclimated to the terms, to the wording of the endoscopy, probably to the two main techniques. And then in the labs, you will go directly on, and it will be, for the beginners, it's no need to have a practical experience before, of course.
We start with the endoscopy course in the lumbar spine, and we have different approaches. It depends to the access points in and the natural holes of the spine, lumbar spine. So we start with interlaminar approaches as well as transforaminal approaches, and biportal as well. So you have your full package for a beginner to start, get used to the endoscope. I think that's really unique in this course.
And the advantage is that you have a lot of firms providing materials so you can have a look to the different material you can use in your institution to make a choice if you have to discuss with your administration or your boss, because of course endoscopy is not only a surgical skill. It's a lot of new material. It's demanding in terms of learning curve, but it's demanding in terms of administrative and financial discussion. And so you will be able to test different column, different camera or techniques. And so at the end, you should be able to have your preference between techniques and probably preference between the providers.
So at this point, maybe I could announce, the industry partners who are coming. We will have 5 industry partners who are there. We have RevoSpine, we have Joymax, we have Artrex, and we have Nexon. And we also have an education company who is coming. Its name is Simulatory. Now, all these industry partners, you could also have a look at their offers, and as Bertrand has said, this may be a good way to take back to your institutions. I have another question here from Anita Shug, actually, and I think this both chairs can really answer this very, very well. Is the endoscope in spine surgeries actually preventing instrumentation in patients, therefore trying to preserve the stability as much as possible?
That's
Splendid
actually excellent questions. You focused on one of the main topics we have to discuss in the courses. For sure, Bertrand and I, we are used to using the endoscope. So for us, it's probably another tool in the toolbox. And coming from my experience, transforaminal approach is an excellent option to preserve us from fusion, to be honest. So, but that's only a small overview of what's possible. So we will discuss this in the courses as well.
Yeah, the same.
I have another question as we wait for other questions from the participants. What about your previous experience? If you want to join the advanced course, why would it be worth, what is your experience, and why would it be worth to join the advanced endoscopy course?
So once you start with endoscopy, you usually start at the lumbar spine. And then once you're used to the lumbar spine, you see the advantages of using the endoscope, you want to treat the other parts of the spine like thoracic and cervical. And we wanted in the advanced course to focus on that, as well as on endoscopic fusion. And this with the monoportal and biportal approach. So we have for the advanced course as well as monoportal as well as biportal, and we have cervical, thoracic, and endoscopic fusion as the main target. I think one of the good things of these courses is that everybody rotates in between, and everybody has only a small group of surgeons, a maximum 4, will come to one table, and they will hop on in between the different stations. So they get used to all of the techniques which we show. That we get really good feedback the last years from this. And to be honest, I'm so happy to have such an excellent faculty with us. So it's not only Bertrand and me, it's Christoph Siepe, Ralf Wagner, Adat Baranto, Thibaut Remacle, Joseph Christini, and did I forget somebody? No, I think that's 7 of us. So you see, you have really great teachers showing you the technique.
If we want to consider the learning curve, because I'm an expert in learning curve, I'm not sure that any techniques, it can be discussed, but I'm not sure that whatever the technique you will use, monoportal or biportal, it will change your life considering only the first indication in chronology of learning curve, that is lumbar discal herniation. Most of surgeons begin with this indication because there is a lot of frequent patient, frequent indication, and it's a very good way to begin your life of endoscopic spine surgeon. And whatever the technique you will choose, you will begin with this because it's standardized and it's quite easy. But I'm not sure that comparing to other minimally invasive techniques, it will change the outcomes for the lumbar discal herniation. But endoscopy is much more interesting concerning decompression, lumbar stenosis, foraminotomy, cervical foraminotomy, and it gives a new life of posterior approach for cervical spine. And fusion, it can be discussed, but I think that the advantage of the advanced course to prove that it's not a techniques to remove a lumbar disc, but lumbar disc is only a good way to begin your learning curve and to go to very interesting procedure, which for me are the lumbar decompression, and that's really a game-changing surgery. And it's perfectly fit with the previous question of the de-escalation of the indication. Provide a decompression without fusion, consider a less invasive, less complex, less implant surgery, and that's very interesting discussion topics for us.
I have another question here from the audience, and this is from Mohammed Gorbel. And his question is, in your view, does unilateral biportal endoscopy offer any additional patient benefit compared with tubular minimally invasive spine surgery?
I quite already respond to this question. If you speak only about lumbar discectomy, I'm quite sure that it will be difficult to prove any difference in outcome, probably less postoperative immediate pain, and I'm not sure. And I'm sure that the late results are the same. And even in my, for example, in my institution, we are very involved in ERAS techniques, and in ambulatory surgery, it don't change the length of stay. But once again, the most interesting indication concern lumbar decompression, lumbar fusion, cervical level, and that's the procedure there, which are very interesting with UBE techniques. And to be good surgeons with this indication, my advice would be to begin with lumbar discal herniation, even if we won't see a very different outcome in this specific indication, but it's a good way to build your learning curve.
Frank, do you have a comment on that?
I think Bertrand is perfectly right. So once you start with the endoscopy and you think about what are the advantages, you have to read some papers about infection rate in endoscopy, to be honest. That really proves us completely right in changing to even more minimal invasive techniques like endoscopy in spine surgery. So infection rate close to 0. That's if you just have such a good technique to get an infection rate close to 0, that's the main advantage for your patient, to be honest.
So I would move on to some other questions regarding access and to training in endoscopy. So the first question I would like to cover here is from Paiman Salsian Teran. And his question was, in order to become an experienced endoscopic surgeon, which path would you recommend if no endoscopic procedures are offered in your own hospital? Is it possible to learn everything on your own with hands-on courses, hospitations, and self-learning? I think this is visitations, right? Are there other
Mhm.
learning opportunities you would recommend? And he's thanking you for your insights.
For sure, you have to learn it like this, as long as it is not in our usual education schedule in the teaching hospital. So we have learned it this way, like Bertrand and me. So we took some courses. We had some help from faculties visiting to places, and to help colleagues in their first cases. So that's the way to start. Actually, that's the idea behind our courses, to get you as a door opener to these techniques, you know.
Same experience. Same experience. It's like every surprisingly there is already a lot of paper concerning the learning curve in endoscopic
Ja,
techniques,
sag mal.
both techniques. I've already Deutsch sprechen. And you will find that you can be considered that acceptable average endoscopic surgeon after 70 procedures. And of course, you will be able to do surgery before having operated 70 patient, but you can't learn endoscopic procedure in one day. We can do the best that we can to make a hands-on, to present you different techniques, and to make you feel the instrument, do the procedure on the very real, incredible, realistic models, and meet the firm you can choose. And then afterwards, of course, EUROSPINE is provide this week, but you can find another course. A lot of firms organize their own course, but it's only with their own material. We are more holistic, and then you will make your choice. And of course, like every learning curve, find an expert, go to see the expert, invite the experts in your institution, and then you will progress. But I confirm that in endoscopy, it's not a surprise, and we won't lie to you, but the learning curve is long and demanding. That's true.
So I
So
think this
there's
is
actually
really well.
a
Oh,
good
sorry.
question, Julie, from Claudius. Is it possible to do both days as a beginner, or is a real world experience in between necessary? What do you think, Bertrand?
Yeah.
So actually, we set up these courses so you can attend both in a row. So
Yeah,
you
sure.
start with the introduction course and then go to the advanced course. Or if you are already experienced and have lumbar spine endoscopic experience, you can go to the advanced course and see what's possible in thoracic cervical cases, how to start with endoscopic fusion is and discuss complex cases with the faculties there. So
There
you
was
will
this
see.
interesting question as well from Anita Shug. How many
Yeah.
courses did you visit before your first case?
Uh,
25. No, I'm just joking.
And the other one was
For sure.
70.
So for me, it was two courses,
me too.
different companies. So there were only one endoscopy course in each company, and there were only two companies starting with endoscopy years ago. So I had one course each, and then when we decided to start, I had a training session with the faculty before we started, and help from in my first two cases as well. So that's how we started.
So
For
you
me,
were saying,
I assisted to course to one of monoportal and one of biportal, and I choose the second option, and I will explain you why probably during the course. And but I went several times in the hospital of Joseph Christini. We will be one of the faculty in Strasbourg. He was a resident of mine, and now he teach me. It's a good story when the resident became the teacher of the of the old teacher, and he came in my institution when because I came back in Paris with all he learned to me, and I tried to adapt this in my own environment, and then he came and he helped me for my first cases. but it was only 2 courses and 2 visits in his institution.
So maybe I could reiterate again for the audience here that during the Edu Week and the endoscopy courses, we will have 4 industry partners, and this gives you more opportunity actually to choose what is most comfortable for you. And then, yeah, and I think there is another question here from Anita Shuk.
Very
We
interesting question.
Yeah, and maybe you could discuss this. I mean, I could say it first. Instrumentation is expensive. Is endoscopic spine surgery in disc herniation removal, stenosis, an option in cost-effective terms in low-income countries? Are the industry supporting initiatives for surgeons who are interested, or is it only available for rich countries? So this,
Oh,
both of you can discuss this
yeah.
extensively.
I can discuss for France because we are a rich country, that's sure, and especially in the medical health system. But when we began to do endoscopic surgery in my institution, the director said, "Okay, you have already hundreds of lumbar discectomy. We bought you 10 matrix system, and you want to go to endoscopy? We have to buy a column, we have to buy a camera, we have to buy specific ancillaries, we have to buy generators and new dropping system specific, and the water. And water is not very green because you use a lot of water for do your procedure. It's not good for the planet. And and in the French system, at the end, it's exactly the same amount of money for the hospital comparing to an old retractor to do the same procedure in 20 minutes, comparing to I don't know, for the beginners, 1 hour, 1 hour and a half for the disc herniation. Of course, you will decrease this time after your learning curve. And it was a hard discussion, but once again, we present that to our director, explaining it won't be focused on lumbar disc herniation. It's for more complex procedure, that it was a real advance, a real wave in all the world of spine surgery. And it will be very good for the institution to make some communication on this, and for our patient, for the GP, and for the correspondent, it was very interesting information. And at the end, we earned the ability to go to endoscopy, but it was a fight because we have a rich country, but the discussion of the expensive are the same. But for the company, you can always find they always are okay to organize course for the resident or for the beginners, and but the discussion remains. It's expensive, and but we have to go on, and every country has its own system, and to have to discuss with the administration. I don't know, Frank, how you do with your administration?
Yeah, that's always a question. Even in rich countries, if you have an invest, for sure you should think the same things Bertrand just told you, and for sure at least once you start with a new technique, it's always part of the investment. But once you invest it, and the more patients you treat, the more income you get for your hospital as well. And your patients will love it, and so they will tell other patients, and so you gain more patients, and you improve. So it's good for the hospital, and it's good for the whole society in your country as well, because you get if you do it right, you get less complications in it. Yes, so I think it's a good option. If you think for biportal, for example, I think that's because a lot of people like it as well, because you might use an endoscope, a straight endoscope, which is already in your hospital, and you can use your instruments you have
That's good you
already
say
for
that, because
tube.
you're a monoportal guy, so it's good to
Yeah,
to.
but it's the truth. So
You're
I think
absolutely
that's
right.
a big advantage.
When we began, we used the column of the and the camera of the orthopedics guy. We use our own Kerisons because it's possible to do with the biportal techniques to use your own. You don't have any investment. Of course, it's better to have a dedicated ancillary, but you can use your own open surgeries instrument, Kerrison, forceps, and with very few specific dedicated instruments. And we took the camera of the guy of the knees. It was a discussion about schedule, but that's the way we began, and it was a minimal investment for the institution. Now we have our own systems, but the first year we organize with no investment.
There's another question here, a bit of a content. So from Marcelo Rodriguez, how far lateral do you think we can go in an interlaminar endoscopic route, whether ipsilateral or not?
We begin.
Ipsilateral over the top. You can do it both. So you can go really far lateral, and you can do it transforaminal as well. So this is a good question. You should attend a course, then we show you.
I think so.
Advanced. Direct advance.
Yeah.
There is another question here. The rate of redo surgeries or revision surgeries, I guess, after first endoscopic surgery. Do you have any experience?
Yes, for sure. We will show it in a talk in the course as well. How we performed our first surgeries, and it was comparable. The first 50 ones were really good. They were as low as, for example, in microsurgical approach and technique. And then once you feel confident, the numbers raised, and then we just attended another course to redefine our technique, and then we get an even lower rate of re-surgery. Does this answer at least a little bit of it? So I don't want to give you all the information of the course, you know.
I think they have to attend the course for that.
Yeah, for sure.
Maybe one
for sure.
last thing. Do you think there are benefits in terms of ergonomics and fatigue of the surgeon while performing endoscopic surgeries in comparison to microscopic spinal surgery?
Bertrand, what do you think? For me, yes. There is a fatigue.
Yes, sure. But depends of your own techniques and depends of what you have in your own operating room. If you have a microscope like I have, it's very. I like to do minimally invasive procedure with a microscope, and it's very comfortable. But considering the advantages of the visualization on the big screen you have now directly in front of your head, you have to think about, but it's a discussion we could have in during the course, how you can manage your own space around your operating table, or you will put your C-arm and the screen of your C-arm, or how you will manage your patient to be okay with your arms and forearms, not to have fatigue, because you have to learn new movement, but it's part one again. We spoke a lot of learning curve tonight because it's main point of a course. But after a few procedure, you will be very confident in this, and you can do a lot of procedure all a day, several procedure without have a fatigue of your arm with ending the instrument. It's quite demanding at the beginning, but that's drawbacks, but the advantage of the huge visualization in front of you without have glasses or micro glasses of microscopes, it's the advantage are superior to me at the end.
So, cheers.
Yeah.
It has been really great, and we're on the time itself, but I mean, I will answer some of the few questions here. That there were some questions about recommendations of books and literature. Please attend, and you will have that as well. And the other one is if we do have bursaries available for low-income countries. As you know, EUROSPINE is trying their best. We are trying our best to have access for many of this. So this is on the way, and we are really working on this. So we hope in 2026 we would be able to offer these bursaries, and with a growing number of industry partners, we might be able to offer this in 2026. So I'd like to thank Frank and Bertrand. I hope the people who have attended today will have the very big, wish to come and see us in Strasbourg. I am really looking forward to welcome you guys there. And we hope that please attend the endoscopy course and see you there. Okay? Thank you. Goodbye.
Bye
Thank you
bye.
very much for your attention.